going on, everybody? Welcome back to yet another episode of the Core Consults RX podcast. And if you'll notice, across the table from me today, no Cole. It's our long-lost buddy, AJ, who is back finally from his vacations and travels, which were numerous, I might add, to finally get back to work, and just in time for Cole to be sick for the second week in a row and have to take his place. So already in the new year, Cole's not looking good. Just really starting to question his, sort of his dedication to the podcast. That's fine. And then, we haven't put out an episode in, 3 weeks now because of the holidays. Then Cole got sick. Then me, my wife, and my 6-month-old decided to all get COVID for New Year's. And then Cole got sick again. This has been a rough go of it. So AJ was nice enough to step up because it was about to just be me in here just talking to myself. So to save you guys from that nonsense, we went ahead and AJ stepped up. I'm going to do a patient case for you guys. We kind of whipped one up based on our colleague, Alex Hovey's one of the PAs we've both worked with. He had a pretty good patient case that he had talked to me about anyway, so I figured we'd turn it into an actual episode. AJ, how's school going, man?
It's going, man. We're about done. Pretty much a pharmacist at this point,
Yeah, well,
there's nothing else I'm going to get. Nothing else I need. I've got it all.
Is third year finally giving you a little bit more trouble? Because I know first and second were pretty easy for you.
We're on that downslope, man. It's all cruising from here. Just oncology from now on. Just the basics, the simple stuff. Oncology, immunology.
Because
nothing crazy.
You start rotations in May, right?
Oh yeah,
that's coming up.
I'll be in Hawaii.
First rotation?
Oh yeah. You already know.
Of course you will be. So, while AJ's thinking about Hawaii, we're going to run through this really quick. I'm going to switch screens. When I switch screens, I actually hit the off record. I stopped recording for a second, so there'd be this weird glip if you're watching the video version. If you're listening, it just sounds like I'm talking for no reason. But so if you are listening or watching the video version on YouTube, if you've never checked that out, check out our YouTube channel. It's nowhere near as cool as our Spotify and things like that as far as number of listeners. So trying to push some more people that way. If you like the YouTube platform. But if you're watching the video version, you can kind of see this on my screen here. But 63-year-old white male, problem list just based on the chart, bipolar II disorder, specifically with major depression. At this point, insomnia that's uncontrolled, epilepsy that's uncontrolled. The patient has a history of tonic-clonic seizures. It does have a history of dyslipidemia and hypertriglyceridemia, hypertension, recent weight gain the patient's complaining of, a recent history, I should say, of hyponatremia, and also type 2 diabetes. But for the first time ever in one of our patient cases, it's basically controlled, or is controlled. So, just a little extra tidbit. Medications, get ready for this one. So medications, Clonazepam, 2 milligrams at bedtime for the insomnia, Risperdal, 2 milligrams twice daily, Carbamazepine, 200 milligrams twice daily, Divalproex, delayed release, 500 milligrams 3 times daily, Levetiracetam, 1,000 milligrams twice daily, Losartan, 100 milligrams daily, hydrochlorothiazide, 25 milligrams daily, Atorvastatin, 40 daily, Fenofibrate, 48 milligrams daily, and our old buddy Metformin ER, 500 milligrams twice daily. So the complaints of the patient is bringing up at this current appointment. Basically, the patient has seen multiple neurologists, multiple psychiatrists, and we did actually, or the provider that was dealing with the patient in the primary care setting did reach out to both neuro and psych, who I will say in this particular instance weren't the most helpful. They're kind of the meds look fine. But as you can see, there's a lot of overlap, and we had to figure out what was being used for psych purposes, what was being used as an actual anti-epileptic. And so that part was pretty confusing at first. And so, besides having to go to multiple appointments, see multiple providers, the patient just says that the Risperdal and Divalproex, so we basically found out from other charts and whatnot that they're being used for the bipolar disorder, the major depression. The patient is experiencing depression symptoms that have been going on for several months now. The history of hypomania is from a couple years ago, and it's not something that he's had any issues with. There's no cycling or anything. And the hypomania isn't super well documented anyway, so there is that little bit of not to jump, and get out of my lane too much, but there is that discrepancy between true hypomania and then something like depression with mixed features, which has some of the hallmarks of and symptoms of hypomania along with the depression at the same time, and they can be treated similarly in some cases, but we do have some data with like Latuda for mixed symptoms, so we've talked about that in our depression episode. But the patient. The family actually, which the family is really helpful in this situation. They say that the patient has been uncharacteristically aggressive lately, and it basically becomes very agitated over like very minor issues, which never was an issue before. The family has also noticed that while they're talking with him, that he's doing like kind of like face grimacing, that his tongue is sort of like protruding from his lips here and there. He's doing other like facial movements, and so they were taking that as like him getting angry while they were talking to him about whatever it was. So we'll come back to all that because there's a lot to unpack with that. And then the Clonazepam for insomnia. So the insomnia symptoms were helped for a couple weeks when the patient was first on Clonazepam. The patient was taking initially Clonazepam 1 milligram and Zolpidem 5 milligrams. And after asking the patient how he was actually taking them, it was basically the Clonazepam 2 hours prior to bedtime, and then Zolpidem about 30 minutes prior to bedtime. Said he didn't feel like the Zolpidem was really helping, and so that was discontinued. Clonazepam was increased to 2 milligrams, and that's been on board now for like 8 months. Now basically back at pre-treatment baseline as far as symptoms go, not sleeping. It takes him a very long time to actually fall asleep. Once he is asleep, he can stay asleep, so it's the sleep onset insomnia, but it's been going on for several months. And the other thing that was kind of interesting is this patient was just recently hospitalized, not for a long period of time, but they were stabilized pretty quickly, but they were hospitalized with hyponatremia. And the other thing is the seizure control has not been sufficient at all lately. So over the last like 3 months, the patient's been having multiple seizures over the course of a month, at least like 1 or 2 a week. And so the family is obviously concerned about that as well, especially with him being on so many anti-epileptics. The blood pressure, triglycerides, we'll address those as well. So the blood pressure today is 144/86, so nothing too crazy, but we still would like it down a little bit. Less than 130/80 would be ideal. Lipid panel, the LDL was 98, and the triglycerides were 245, down from 423 4 months ago. At that point, the Atorvastatin was started, 40 milligrams was started, and the Fenofibrate at the same time. LDL came down quite a bit, and then triglycerides also, but still up there a little bit. And the CMP was all normal. The sodium you can see is still a touch low, but it kind of has been staying in that ballpark of 132 up to around 138 or so. eGFR is normal. The hemoglobin was 10.1 and MCV was 73. And at ferritin levels, we went ahead and got an iron panel. Ferritin was 17. The good news is the A1C was a 6.9. So good job, metformin and lifestyle management. AJ.
That was a mouthful.
That was a mouthful.
The biggest thing I think about when I go through these anti-epileptic medications is the CYP inducers. So carbamazepine always scares me. I don't know. It scares the bejeebies out of me because of the autoinduction for 2C, 3A4. I'm like, okay, so all of them pretty much as we're going through everything. And then I see Levetiracetam, we see Losartan, Atorvastatin. I'm like, okay, what's going on with the blood levels here?
And for those of you who are not familiar, basically the carbamazepine has an autoinduction, so it's a inducer of the substrate, a CYP, a few different CYPs, and it's a substrate of those same CYPs. So it's like you can get to steady state, and then like a 4-week period will go by, and they're no longer at steady state. So it's got some stupid kinetics going on. But the other thing that a lot of people don't realize about it is it can cause hyponatremia, SIDH, and hyponatremia is more in the post-marketing kind of surveillance that they've seen, but it's more common than you probably would think, especially if there's other medications that could also potentially cause hyponatremia. So the patient was also on HCTZ at the time, so that could have played a role as well. But the bottom line is the patient actually has was wanting to stop that anyway. I guess the family at least did their own research and saw that can happen. And as far as the aggression and that type of behavior, the Levetiracetam has been known to cause like behavioral disturbances like that. So patients that have psych disorders and things like that, you have to kind of watch out for changes in mood and whatnot when you're on Levetiracetam. It's not something that we have to deal with. I mean, Keppra is a very common medication, but it is something that you at least want to have like kind of on your radar. And so a couple things right off the bat, like the Carbamazepine, because the other part of that is, is that being, in this case, it's being utilized for epilepsy, but was it kind of one of those things that, we can use as a mood stabilizer as well. They try to kill two birds with one stone, so to speak. And so, when it comes to looking at, the different seizure types, here, I'm going to switch to my screen again. Different seizure types. This is just a kind of a summary chart that I put together based on some different sources. But you can kind of see he's got tonic-clonic seizures. So carbamazepine is a first-line option. He's also on Divalproex, which is another first-line option. That being said, the seizures are uncontrolled, and the patient is still experiencing way more than we would like. So, in the spirit of killing two birds with one stone, my recommendation when discussing with the provider was, why not sort of cross-taper the carbamazepine off and then start to slowly titrate the lamotrigine, titrate the dose up. You have to go really slow with lamotrigine dosing. That's why it even has like starting packs because of the skin hypersensitivity reaction, Stevens-Johnson syndrome, things like that. It can happen if you go too quickly with the dose. We definitely don't want to cause any other problems with this patient. So lamotrigine, starting off normal, 25 to 50 milligrams, and then working our way up slowly from there. And we went ahead and decided to give that a try, got rid of the carbamazepam and got rid of the Levetiracetam as well, since that may have actually been being counterproductive when it comes to the psych disorder, the mood stabilizers and whatnot. So that's carbamazepine gone, Levetiracetam gone, and we started adding lamotrigine.
I like lamotrigine a lot just because it's got so many different mechanisms. You can use it for more things than, like, say, carbamazepine, which is just focusing on sodium channels. You've got sodium channels, calcium channels, and glutamate, which are all major neurotransmitters in the brain, and these voltage-gated channels that contribute to so many of the different neurological disorders. I feel like it's important to start hitting multiple mechanisms of action if you're going to try to approach different disease states for the same drugs, off-label uses. And
you'll also see lamotrigine used very often in bipolar disorder. So that's where I was saying we can kind of utilize this as our mood stabilizer. And it's actually been used in combination with Divalproex. There's some data in patients with bipolar disorder or bipolar major depression utilizing lamotrigine and Divalproex as well as neuroleptic as well. So this patient's kind of right, in that kind of that med combo grouping. But the other issue is with I think the mood is being kind of shaken up a little bit, so to speak, by the Levetiracetam. I think that is playing a role. But the patient, even if the patient's depression symptoms were perfect, which they're not, the Risperdal is now causing tardive dyskinesia, is what it sounds like, which, if you remember, like our initial, first generation antipsychotics, our typical antipsychotics, they were, especially the ones that are higher potency, like haloperidol, they're much more likely to cause tardive dyskinesia than our newer agents, our second gens, or our atypicals. But risperidone, a lot of times people refer to it as like the most typical atypical. And so it does have one of the higher chances of causing, those type of movement disorders. So tardive dyskinesia in particular, like this patient's experiencing, we have things like pseudoparkinsonism, dystonia, akathisia, those types of things you hear about. They'll lump those under the umbrella term of EPS. A lot of people don't really like that term because it's such a broad term, and you can treat the individual types of quote unquote EPS very differently. So in this case, tardive dyskinesia, we want to get rid of the offending agent, so that we don't, run the risk of this becoming a more permanent thing and have to have the patient on, one of those Austedo or one of those meds that are quite expensive. So discontinuing, or at least tapering off the risperidone, but we need something to replace it. And since the patient's, not having their symptoms controlled anyway, and they're also having insomnia, which I imagine there's probably a little bit of anxiety component to that as well. And we're going to talk about the insomnia meds, but my thought was, at this point, maybe tapering off the risperidone and giving the patient a chance to try quetiapine. It has good data in patients with bipolar disorder, and it also, and specifically bipolar major depression, and it also has the fatigue or the sedation associated with it. So it works really well giving that at bedtime to help kind of induce sleep for a lot of these patients. Now you have to worry about the hangover effect, so to speak, in the morning, because if it lingers too long or the patient takes it too late in the evening, goes to bed too late, they may feel some of those residual grogginess the next day. But it does work as a pretty good option when you have a patient that also has some insomnia present. And since we're already doing the lamotrigine, the quetiapine and lamotrigine actually is a combo that's been studied in a few different studies for bipolar and major depression. And so it's something that I think that would be a good kind of trial. And then if that's not, not sufficient, or, the patient doesn't like the side effects of it or whatever, because quetiapine can cause some weight gain and some increases in appetite and some metabolic changes like glucose intolerance and whatnot. Not nearly as bad as like olanzapine, but they can cause some problems. And but it does have a lot less likelihood of causing like the movement disorders and things like that.
I think about ziprasidone too, but I feel like it's less efficacious than olanzapine or Risperdal, things like that. But you've still got much more of the sedating effect.
So yeah, and the quetiapine especially, like in this particular case, but ziprasidone is actually, I've used that several times for patients who have failed other antipsychotics that worked really well. And the one thing I don't like about oral Geodon or ziprasidone is you have to take it with a full meal. In fact, they actually say 500 calorie meal twice a day. That's pretty annoying. And so that can be kind of hard on the adherence piece of it. Plus it doesn't have the sedation associated with it, but it does have less likelihood of side effects as far as like the weight gain and things like that. You do have to watch for patients who have like a prolonged QT interval, or patients who are on other medications that can prolong that QT interval, because it can do that as well. But it's usually only in older patients who have an issue that we have to really worry too much about it. But I definitely would say have that in your back pocket. What do you think about clonazepam for insomnia, AJ, since we talked about that in a previous episode?
I think that's an option. I don't think it's the best option, but I think it's definitely something that I can see that the providers are trying here. As we move forward, we've definitely got to do something with it. I don't want to keep it on, especially considering all of the GABA effects and things that we've got. I would taper it off.
Yeah, especially if it started working initially and then now it's kind of like losing its efficacy. The patient's not really getting any symptom relief from it. A lot of times these, patients that a lot of times even like 8 weeks, the body almost becomes like dependent to some extent, and the tolerance definitely is there, but it becomes a little bit dependent on the benzos, which is why we don't really like those for long-term, insomnia treatment. Now, previously he had mentioned that he was taking zolpidem and a lower dose of clonazepam, but that the zolpidem wasn't doing anything. But the way that he was taking it, the clonazepam was being taken earlier, and the zolpidem at that point, which is more specific as far as the benzodiazepine receptors that it's binding to. The clonazepam is going to be kind of non-specific. It's going to bind to 1 and 2, whereas the zolpidem is going to be more focused on 1. So it's not going to have the anxiolytic type effects. It's not going to have those muscle relaxer type effects. It's just going to cause the sedation and hypnotic type effects that benzos can do. And so if you're already activating those receptors, you're going to have limited binding capabilities with the zolpidem potentially. Now, obviously, the way it really plays out and with different binding affinities and whatnot, that might not be 100% accurate, but it is interesting that the zolpidem didn't work at all, and then he went up on the dose of the clonazepam, and at least at first it did. And it also too with, the other meds going on and side effects and stuff, I'm sure there is an anxiety component. So that's the other reason why I'm hoping that quetiapine will be a good option for him. Now, I still want to titrate the clonazepam off regardless, even if it is anxiety and things like that. But if we are going to have to go the hypnotic route, let's say the quetiapine is just not enough, he's not sleeping, plus he's feeling really fatigued during the day because of the sleep imbalance throughout the night, If we are going to have to go like a hypnotic route, I would probably do escitalopram. There was a study, or a meta-analysis, I should say, that was looking at basically efficacy, safety of the orexin inhibitors, the different hypnotics, the benzos, things like that. It came out in, I believe it was like August or something like that of 2022. I can link it in the show notes, but basically one of the drugs that has more long-term data is Lunesta. And it has been shown to be at least some safety is not the right word. Safety in the fact it's not going to necessarily cause direct harm, but it's still not something we want them on long term. But at least we have some data to support its more long term use, efficacy wise. But there is more side effects. Patients complain of metallic taste. You still got to worry about the fatigue the next day, and so there's definitely not something that you can just put on and then just indefinitely have the patient, on that medication. But that would be the next one that I would try. Definitely not a benzo in this particular case, especially with all the other stuff that's going on. And hopefully that the patient has access to some kind of a therapist or a cognitive behavioral therapist, something like that, which if we can get somebody that also has some experience in cognitive behavioral therapy for insomnia, like we talked about in our insomnia episode, that can be very good combo between that and actual hypnotic drugs.
You got to keep your eyes on the anticonvulsants and muscle relaxants when you're taking that escitalopram too.
Yeah, that's a very good point. And that's the reason why I said, let's try with the quetiapine, taper off the clonazepam. We're not just going to stop it cold turkey, but taper that off. And then while the quetiapine dose is being increased, and then hopefully we don't have to go that route, but definitely age is 100% right. You got to be careful with all that different stuff, because a lot of ups and downs with your neurotransmitters. So we'll jump real quick into the blood pressure. So the Losartan, 100 milligrams, I'm cool with that. I like ARBs a lot. One thing I would say, Losartan's half-life is, fairly short. It's definitely not 24 hours. I think Losartan might be 12 hours or less, actually. But you might get a little bit more bang for your buck by splitting, especially since he's so close to being at goal. Relatively speaking, compared to a lot of our other patients that we talk about on here, 14 millimeters of mercury systolic. You can, with lisinopril, for example, when you switch from 40 milligrams once a day to you switch to 20 milligrams twice a day, you can get like 10 more millimeters of mercury drop in the systolic blood pressure by dosing it on the half-life. So, same kind of thing can happen with Losartan. So if the patient's willing to, they can keep the 100 milligram tablets, just break them in half. They're scored. They're really easy to break. And just do half in the morning, half at night. I would stop the HCTZ. One, you guys know I don't like HCTZ just because of the lack of outcome data, and also the hyponatremia risk with it, along with the other stuff that he's on. It can affect lipid panels in a negative way in some cases too. Not usually we don't worry about that clinically, but there is some effect on the cholesterol panel. So I would say get rid of HCTZ and maybe do like 63-year-old, so you might even be able to get away with like a 2.5 milligram amlodipine. Have them take that with the half milligram or the half tablet of Losartan in the morning, the other half of the Losartan at night. I think the blood pressure would be less than 130/80 would be my guess, as long as he can tolerate it.
You can tell he's making those lifestyle changes and things too with his diet.
Yeah, for sure. The other thing was kind of weird is the lipids. So the LDL 98, based on everything else going on, I would be probably pretty good with that. Probably has a lower, we can calculate it, but probably a lower ASCVD risk because there's not like any history of cardiovascular events or anything. Doesn't smoke. Blood pressure is not anything crazy. But, Atorva 40, I'm cool with that. The Fenofibrate, I'm not really that big of a fan of. In fact, some guidelines will say not to even use a fibrate until like the triglycerides are over 1,000 and you're just really worried about pancreatitis risk. Fenofibrates just lack the outcome, data that especially something like statins would have. So this is a classic example of why if you're going to go a high intensity statin, my go-to is always just to jump right to with the Atorvastatin, I jump right to 80 milligrams. Because one, that's all the outcome studies with the Atorvastatin have all been with 80 milligrams. There's like one that did 40 milligrams if they couldn't tolerate 80. And then two, you have somewhere to go. If they do have some myopathies, myalgias, you can decrease the dose to 40. And then, we know that the Atorvastatin's a lipophilic statin. Let's say they're still having muscle aches with that dose decrease, but we need the high intensity. Switch them to Rasuva, hydrophilic statin, and on
20 milligrams?
The way that they're looking at it, yeah, exactly. It's much more aesthetically pleasing to the eye. It looks like I'm still cutting that dose in half, but we know. And then, from there we can get tricky and do every other day if we had to and things like that. But there's lots of room to go. So that's my personal kind of like strategy when I'm thinking about statins. But this patient, they do have a history of diabetes, triglycerides above 130 and less than 500.
I'll tell you what, man. As a pharmacist looking at these labs and then looking at the medications, I don't have a problem with taking Fenofibrate off right now, especially considering we're on multiple antipsychotics or he's diabetic. These are good labs for normal folks.
Yeah. So, and the triglycerides came down, that huge drop from 423 down to 245 when he got better control of his diabetes and he started the Atorva at the same time as the Fenofibrate. So I doubt 48 milligrams of Fenofibrate's doing all that much. If we were going to add something potentially, now I would say let's jump to Atorva 80 first, because we can push the LDL lower, who cares? And that would take care of the triglycerides as well. If we do need something else on top of that, triglycerides are still above 130 or 135, then we can always add icosapent ethyl under the brand name Visipa. It's a purified fish oil. It's the one that actually has some outcome data with it from the REDUCE trial. Now, the REDUCE trial does have a little bit of controversy surrounding it because, like the placebo arm, they used mineral oil, which can negatively affect someone's lipid profile and whatnot anyway. But there's been a lot of, kind of secondary analysis and whatnot. And so I feel pretty good about saying that, it's something that I would still consider adding on to this patient. Plus we're not really thinking along the lines of triglycerides as much as we would be LDL, but bempedoic acid, I think at least the preliminary data is looking good for positive outcomes on top of just lowering LDL. So if we needed to lower the actual LDL lower, we'd have that in our back pocket. But this patient would be a good candidate for icosapent ethyl if the Atorva 80 wasn't enough to get the triglycerides down. And honestly, the patient's probably still drinking some and, other things like that that's keeping those triglycerides up. So that would be my thing. Get rid of the Fenofibrate. He's already taken enough stuff. And that way we can kind of maximize the Atorva as long as he can tolerate it and go from there.
That's the first mechanism I'm not sure of.
Which one?
I'm not proud of that, how that Visipa raises the HDL and doesn't raise the LDL. I had to figure that out.
Well, all of them will raise the HDL and lower the LDL.
But that one's like very, so, I went through my little database.
Yeah.
Visipa's actually like more known to reduce the triglycerides, increase HDL significantly. Like you're not going to get that kind of HDL raising with the statins. But with Visipa, there's something about the icosapentaenoic acid that's going to make your high density lipoprotein increase in the body. But I'll do some research. I'll have something for us.
Follow up with us next time. Yeah. I like that. The other thing to keep in mind is if the patient has a history of AFib or atrial flutter as well, that risk can be a little bit higher with icosapent ethyl. So just use caution in that patient population. But other than that, the other thing is you got to make sure the patient's willing to take, 2 capsules twice a day of the fish oil. Not the most pleasant thing. That's why I say maximize that statin first. And then the other last little piece, I know, and just so we're clear, these changes for some of this stuff wouldn't be happening all in one visit. It would be like a very quick follow-up, and then other things change. So with the first visit, we basically were changing the lamotrigine and getting the mood stabilizers and the risperidone kind of squared away, changing it to quetiapine, and then we started focusing on the other stuff the next week as far as blood pressure and the rest of it. Just for those of you who are freaking out about all these changes, this is just for learning purposes at this point. That's why I'm going through it as if it's one visit. But the other thing was the fatigue. We kind of automatically attributed that to the patient not sleeping well at night and whatnot. But the hemoglobin actually was 10.1. The MCV was 73, which kind of looks like microcytic anemia, which is typically going to be a result of iron deficiency anemia. Ferritin was 17. So normally when that level drops, especially if usually 30, less than 30 is what we're kind of looking for, we're thinking iron deficiency anemia. We could get a TSAT and, a serum iron if we wanted to, but my treatment option for him, for those of you who are not familiar with the newer iron dosing, I think we've mentioned this on the podcast before, but I typically do ferrous sulfate 325 on once a day on Monday, Wednesday, and Friday only. That whole ferrous sulfate 325 3 times a day, every day, you actually get like this paradoxical less of an absorption with higher doses and more frequent doses of iron than you would with that like every other day dosing. The women's health practitioners, I feel like, are the ones that were the quickest to adopt that, and it really does work well. I've had a lot of patients that switch over, their iron levels go up, and their constipation, all their stomach upset goes away. Yeah. And then the other thing was, kind of having in our back pocket, again, this would be probably 2-3 visits from now. If the weight gain does become an issue, we start bringing that quetiapine dose up. Maybe it's working well, but he's worried about the weight gain. We always got something like semaglutide that we could, and hopefully soon tirzepatide for weight loss. But he's got diabetes, so technically it would be okay. But we could definitely get rid of the metformin because we're not married to metformin as first line options anymore for diabetes. You could get rid of that if you just were trying to decrease the pill burden and give him Ozempic to just kind of monitor that weight and keep his appetite suppressed while he was on these medications that can increase appetite. So I'd kind of have that on standby just in case, and kind of tell the patient that we have that in our back pocket just in case. So just to kind of recap, AJ, to keep me straight on all this. So we are discontinuing Risperdal, so replacing it with quetiapine, titrating the dose up based on symptoms, and hopefully curing some of that insomnia. Stopping Carbamazepine. For now, we're going to keep the Divalproex, stopping Levetiracetam, and basically starting lamotrigine, and then titrating that dose up to cover as an anti-epileptic and as a mood stabilizer as well.
Slowly titrate.
Yes, very slowly. And from the blood pressure standpoint, actually I'm getting ahead of myself. From the insomnia standpoint, we're going to start breaking down the dose of the Clonazepam, titrate that off very slowly so there's not too many abrupt changes, and hopefully the quetiapine dose will kind of take the place of that. From a blood pressure standpoint, we will be doing twice a day dosing Losartan, 50 milligrams, and then getting rid of the HCTZ, doing like a 2.5 milligram amlodipine to start, and then go up if we need to from there. Atorva will go up to 80 milligrams, stopping Fenofibrate, and Metformin will have an asterisk next to it in case we need to get some weight loss. We'll get rid of that too and get the Ozempic on board. What do you think?
I think it's good. It sounds good. Looks good. I'm biased.
Hey,
but
thanks, man.
I got a little clinical pro for you.
Dude, before you say that, I do want to give a quick, just already like, how they do like the thing where it's like, where are they now? In the same episode. So this happened. I got consulted on this patient like 4 weeks ago. And I did find out that the patient has not had a seizure since, and has stopped chasing because he was like he was in an extended stay place for just recently, trying to get all this stuff straightened out, chasing nurses and stuff up the hallways and losing his mind about little things. Hasn't done that at all anymore either. So I think the lamotrigine's working out just fine.
That's an outcome in itself.
That is perfect. So I was very excited to hear that before we started recording.
Now,
AJ, what's your clinical pro?
I was going to say that supplementation with vitamin C actually increases outcomes in a lot of those different disorders where we're using the same antipsychotics. Mm-hmm. So as we're adding ferrous sulfate with the vitamin C, I wouldn't use orange juice, obviously, because it's
ascorbic acid.
Yeah, but ascorbic acid specifically will help reduce oxidative stress, all that kind of stuff. It's pretty good.
Yeah, that's awesome. Speaking of pearls, for those of you who have not checked out our sponsor of the podcast, Pearl's new app. What are you doing? He just updated the app. Now he's got some dosing strategies on there, and there's drug interaction checkers. He's definitely got kind of an overhaul. I mean, the app was already like building already last year, but just released a big update, and so it looks kind of all new when you first log into it. And so very impressed with what he's done over the last year, and he's got big plans for 2023. So
I've got it. I use it.
Yeah, I do too. I saw my wife using it. My wife's pharmacist too, and she was using it the other day. Like sitting on the couch looking something up. I was like, all right, look at Pearls go. But yeah, very, very supportive of the podcast, and they've been great to work with. Really appreciate them sponsoring us all through 2022. So make sure you check out www.pearls, that's PYRLS.com/CoreConsultRx. Sign up for free. You get some free treatment algorithms and charts and PDFs and stuff you can take home. and then and keep, even if you don't want to keep with the free service, and you may even want to upgrade to the Pro service. And it's very very cheap still, and like I said, you won't be disappointed, I don't think. And if you can quit and cancel at any time, even for the free one, you can always unsubscribe your email, but definitely check them out. Like I said, they've supported the podcast a lot, so definitely check them out if you guys can. If you want more like lecture style episodes and not just me running my mouth or, us goofing around, check out patreon.com/coreconsultrx. I have all my PA school lectures on there that I teach for pharmacotherapy. So just are in the middle of finishing up the diabetes series on there now. So we went through insulin therapy, went through all of the type 2 pharmacotherapy, 2023 ADA algorithm, went through a bunch of background information and stuff. We're going to go through like cardiorenal protection for the 4th lecture. And I think it's like 100 slides just for diabetes, but it ends up being like $3 a month or something like that. So I think it's a fair deal. So check that out if you want that. There's a whole bunch of different disease states on there, and we're trying to add stuff on there at least once a week, if not twice a week, with a bunch of pharmacotherapy practice questions, all kinds of good stuff.
You can do what I do.
What do you do?
Just pay 3 months every year.
Yeah.
In January.
Yep.
Get it all.
Yep.
And then just unsubscribe.
There you go. I don't care.
Next year, just read
it. And then share your password with a friend. Yeah, whatever. If you can't afford it, you can't afford it. It's all good. I get it. You guys are some of you are in school and you're trying to learn even more. I'm proud of you. Go steal my stuff. I don't care. And if you want to talk to me, AJ, Cole, our emails will be in the show notes. You can reach us on social media platforms. Sorry we kind of left out episodes for the last bit of 2022, but hopefully we'll get the year start off right. Appreciate you guys listening to us still, and all the support. And we will see you guys on the next episode. Have a great one.